Hello everyone. Today we are going to learn a bit psychology in the sense some clinical aspects along with some important topics related to abnormal psychology. So let's have a quick introduction about the concept of normality and abnormality. The term normal is extremely subjective and context dependent in case of psychology. According to Krivas et al. In 2010, what is accepted to be normal is the pattern of thoughts, feelings, or behavior that conforms to usual, typical, or expected standards in a culture. Then, abnormal is the pattern of thoughts, feelings, or behavior that is deviant, distressing, and dysfunctional in relation to the usual, typical, or expected standards in a culture. No single indicator is sufficient enough to define or determine abnormality. Generally, the following factors indicate whether a person has some form of abnormality. Social context. What may be considered as normal in one social makeup or societal makeup or culture is likely to be vastly different to another culture. Thoughts, feelings, and behaviors which are inappropriate or unusual in a culture are regarded as abnormal. For example, in Southeast Asian countries, it is entirely acceptable for one to spit on the ground to clear one's throat. It is normal. However, in Australian culture, this is largely unacceptable and abnormal. Even within cultures or different groups of people, whether something is normal or not depends on the particular situation or context. For example, carrying a fully loaded rifle may be normal if you are part of an armed forces, but probably not if you are in a restaurant. Violation of the standards of society. When people fail to follow the conventional social and moral rules of their culture group, we may consider their behavior abnormal. Of course, much depends on the magnitude of the violation and how commonly the rule is violated by others. A behavior is most likely to be viewed as abnormal when it violates the standard society and is statistically deviant or rare. In contrast, most of us have parked illegally at some point. This failure to follow the rules is also statistically common that we tend not to think of it as abnormal. Social discomfort. When someone violates a social rule, those around him or her may experience a sense of discomfort or unease. People who walk the streets looking dirty, making bizarre body movements, or shouting at others are widely spotted as abnormal. Such behaviors that make people uncomfortable or cause distress to them are indicative of abnormality. At times, the most important factor is our evaluation of whether a person can control his or her behavior. Behaviors that the society views as irrational, unpredictable, and dangerous are indicative of abnormality. And subjective distress. If people suffer or experience subjective distress, it is indicative of abnormality. Depressed people clearly suffer, as do people with anxiety disorders. Such distress include feelings of dissatisfaction, sadness, anxiety, or lethargy, and physical complaints like nausea, headache, or unwanted thoughts or impulses. Although suffering is an element of abnormality in many cases, it is neither a sufficient condition, all that is needed, or even a necessary condition, a feature that all cases of abnormality must show, so as to consider something as abnormal. An impairment of adaptive functioning. Maladaptive behavior is often an indication of abnormality. Adaptive behavior may be understood as behavior that meets the performance requirements or rule demands of one's situation. The person with depression may withdraw from friends and family and may be unable to work for weeks or months. Maladaptive behavior interferes with our well being and with our ability to enjoy our work and our relationships. And statistical deviancy. The word abnormal literally means away from the normal, but simply considering statistically rare behavior to be abnormal does not provide us with a solution to our problem of defining abnormality. If something is statistically rare and undesirable, like severely diminished intellectual functioning, we are more likely to consider it abnormal than something that is statistically rare and highly desirable, such as genius, or something that is undesirable but statistically common, such as rudeness, that is common nowadays. Not nowadays, it's common. Okay. So, abnormality, and that's not a desirable thing. You must not be rude. So, abnormality may be this understood as significant deviation from commonly accepted patterns of behavior, emotion, or thought. Decisions about abnormal behavior always involves social judgments and are based on the values and expectations of society at large. This means that culture plays a role in determining what is and what is not abnormal. Meaning, definition and classification of mental disorders. Abnormal psychology is concerned with understanding the nature, causes, and treatment of mental disorders. According to the Diagnostic and Statistical Manual of Mental Disorders, Edition 5, DSM 5, a mental disorder is defined as a syndrome that is present in an individual and that involves clinically significant disturbance in behavior, emotion regulation, or cognitive functioning. These disturbances are thought to reflect a dysfunction in biological, psychological, or developmental processes that are necessary for mental functioning. DSM 5 also recognizes that mental disorders are usually associated with significant distress or disability in key areas of functioning, such as social, occupational, or other activities. However, predictable or culturally approved responses to common stresses or losses, such as death of a loved one, are excluded. In brief, mental disorders are patterns of abnormal behavior, emotions, or thought that significantly interfere with an individual's adaptation to important life demands and often cause distress in the individual or in others. Diagnosis of mental disorders can lead to effective and efficient treatment and ideally cure. So, organizing information within a classification system allows us to study the different disorders that we classify and therefore to learn more about their causes, prognosis, and treatment. At the most fundamental level, classification systems provide us with a nomenclature or a naming system and enable us to structure information in a more helpful manner. There are two main systems of mental disorders classification: the categorical approach and the dimensional approach. The categorical approach uses discrete, distinct categories and subcategories to order mental disorders. It uses a systematic approach to classification, outlining symptoms based on scientific research. It is consistent and comprehensive but divisive. It distinctly divides people into groups, which may result in stigmatism and labeling. The categorism approach the categorical approach utilizes two tools to aim in diagnosis: the DSM-IV, Diagnostic and Statistical Manual of Mental Disorders, Edition 4, and the ICD-10, International Classification of Diseases and Related Health Problems, Edition 10. Both classify mental disorders, order them categorically, and use recognizable symptoms to aid their classification. The DSM-IV has 16 categories and is widely used by mental health professionals for diagnosis, whereas the ICD-10 has 21 chapters and is generally used by doctors and psychiatrists. The DSM-IV covers 5 areas: Axis 1, clinical disorders and other conditions, patients, primary diagnosis; Axis 2, personality disorders and mental retardation; Axis 3, general medical conditions that might affect the patient psychologically; and Axis 4, psychosocial and environmental problems; and Axis 5, global assessment of functioning and assessment of the patient's level of functioning. Unlike the categorical approach, the dimensional approach uses scales and continuums to diagnose, quantify symptoms so that they can be analyzed. Strengths of the dimensional approach are more comprehensive diagnosis, unique combinations of mental conditions, and non-divisive approach, not leading to labeling and stigmatism. However, due to unique combinations being taken into account, the diagnosis process can become very time consuming. Also, there are potentially endless combinations, meaning that accurate diagnosis may prove difficult. Anxiety disorders. Anxiety refers to a sense of agitation or nervousness which is focused on an upcoming potential danger. The anxiety response pattern is a complex blend of unpleasant emotions and cognitions that is more oriented to the future and much more diffuse than fear. It has cognitive, subjective, physiological, and behavioral components. At the cognitive or subjective level, anxiety involves negative mood, worry about possible future threats or danger, self At the cognitive subjective level, anxiety involves negative mood, worry about possible future threats or danger, self preoccupation, and a sense of being unable to predict the future threat or to control it if it occurs. At a physiological level, anxiety often creates a state of tension and chronic over-arousal, which led to risk assessment and readiness for dealing with danger if it occurs. At a behavioral level, anxiety may create a strong tendency to avoid situations where danger might be encountered. The adaptive value of anxiety is that it helps to plan and prepare for possible threat. In mild to moderate degrees, anxiety actually enhances learning and performance. It is maladaptive and it becomes chronic and severe as as some people diagnosed with anxiety disorders. Anxiety disorders refers to a category of psychological disorders in which the primary symptoms involve extreme anxiety, intense arousal, and or extreme attempts to avoid stimuli that lead to fear and anxiety. For a person with an anxiety disorder, the anxiety does not go away and can get worse over time. The feelings can interfere with daily activities such as job performance, schoolwork, and relationships. When people perceive a threat, the flight or fight response, the automatic neurological and bodily response arises. This response underlies the fear and anxiety involved in almost all anxiety disorders. When the arousal feels out of control, the person may experience panic. In response to the panic, some people develop a phobia of stimuli related to their panic and anxiety symptoms. So, anxiety disorders frequently occur when other psychological disorders, such as depression or substance related disorders, the high comorbidity of depression and anxiety disorders suggests that the two disorders share some of the same features, specifically high levels of negative emotions and distress, which can lead to concentration and sleep problems and irritability. Mental health clinicians must determine whether the anxiety symptoms are the primary cause of the problem or are the byproduct of another type of disorder. The different types of anxiety disorders are described below, like phobias. A phobia is a persistent and disproportionate fear of some specific object or situation that present little or no actual danger but leads to greater avoidance of these feared situations. There are three main categories of phobias: specific phobia, social phobia, and agoraphobia. Agoraphobia. Yeah, I'm not sure about the pronunciation. Specific phobia. This anxiety disorder is characterized by excessive or unreasonable anxiety or fear related to a specific situation or object. So, specific phobias include claustrophobia, fear of small spaces, arachnophobia, spiders, and acrophobia, heights. DSM-IV lists five types of categories of specific phobias as shown below. So they differ from situation to situation. Okay. So animal, snakes, spiders, dogs, insects, birds, like that. Animal, snakes, spiders, dogs, insects, birds, natural environment, storms, heights, water. Then blood injection, injury, seeing blood or an injury, receiving an injection, seeing a person in a wheelchair. Situational, like public transportation, tunnels, bridges, elevators, flying, driving, and closed spaces. Another choking, vomiting. Space phobia, fear of falling down if away from walls or other support. When individuals with specific phobias encounter a phobic stimulus, they often show an immediate fear response similar to a panic attack. Such individuals also experience anxiety if they anticipate they may encounter a phobic object or situation and hence try to avoid encounters with the phobic stimulus. They even avoid seemingly innocent representations of it, such as photographs or television images. So if you learn to the go to the diagnostic criteria, marked and persistent fear that is excessive or unreasonable, cued by the presence or anticipation of a specific object or situation like flying, heights, animals, receiving an injection, seeing blood. An exposure to the phobic stimulus almost invariably provokes an immediate anxiety response which may take the form of situationary bound or situationary predisposed to panic attack. The person recognizes that the fear is excessive or unreasonable, The phobic situation is avoided or else is endured with intense anxiety or distress. The avoidance, anxious anticipation, or distress in the feared situation interferes significantly with the person's normal routine, occupational or academic functioning, or social activities or relationships. In individuals under the age of 18 years, the duration is at least 6 months. The anxiety, panic attacks, the phobic avoidance are not better accounted for by other mental disorders. Causal factors, neurotransmitters including GABA, serotonin, acetylcholine, and norepinephrine, and role of genes. Psychological factors including apparent conditioning like negative reinforcement of avoiding the feared stimulus and cognitive biases related to the stimulus such as overestimating the probability that a negative event will occur following contact with the feared stimulus. Then observational learning, a social factor, can influence that particular stimulus a person comes to fear. Treatment, medication like treatment include medication targeting neurological factors, then specifically a benzodiazepine. Then CBT is extremely effective, particularly when exposure is part of a treatment. And social phobia. Social phobia is an intense fear of public humiliation or embarrassment, together with an avoidance of social situations which may cause this fear. And such social situations cannot be avoided, they trigger panic or anxiety. So, social phobia may be limited to specific types of performance related situations or may be generalized to most social situations. The anxiety about performing poorly and being evaluated by others can in turn impair an individual's performance, creating a vicious cycle. The symptoms of social phobia may lead individuals with this disorder to be less successful than they could otherwise be because they avoid job related social interactions that are required for advancement. Marked and persistent fear of one or more social or performance situations in which the person is exposed to unfamiliar people or to possible scrutiny by others. The individual fears that he or she will act in a way to show anxiety symptoms that will be humiliating or embarrassing. Exposure to the feared social situation almost invariably provocates anxiety, which may take the form of a situationally bound or situationally predisposed panic attack. A person recognizes that the fear is excessive or unreasonable. The feared social or performance situation are avoided or else are endured with intense anxiety or distress. The avoidance, anxious anticipation, or distress in the feared social or performance situations interfere significantly with the person's normal routine, occupational, academic functioning, and social activities or relationships. In individuals under 18 years, the duration is at least 6 months. The fear or avoidance is not due to the direct physiological effect of a substance or a general medical condition and is not better accounted for by another mental disorder. Causal factors, neurological factors include an amygdala that is more easily activated in response to social stimuli, too little dopamine in the basal ganglia, too little serotonin, and a genetic predisposition toward a side temperament. Okay. And psychological factors include cognitive distortions and hypervigilance for social threats, particularly about being negatively evaluated. Classical conditioning of a fear response in social situations may contribute to social phobia. Avoiding feared social situations is then negatively reinforced or parent conditioning. Social factors that give rise to social phobia include parents modeling or encouraging a child to avoid anxiety inducing social interactions. Treatment medications we require specifically beta blockers for periodic performance anxiety and selective serotonin reuptake inhibitors or selective norepinephrine reuptake inhibitors for more generalized social phobia. CBT is specifically exposure and cognitive recruitment. Then treatments that target social factors include group CBT and exposure to feared social stimuli. Then agoraphobia, agoraphobia. Agoraphobia involves persistent avoidance of situations that might trigger panic symptoms or from which escape would be difficult. Many patients with this condition may avoid places in which it could be embarrassing or hard to explain. Obtain help in case of panic attack. For these reasons, tunnels, bridges, Crowded theaters and highways are typically avoided or entered with difficulty by people with this condition. Anxiety about being in places or situations from which escape might be difficult or embarrassing, or in which help may not be available in the event of having an unexpected or situationally predisposed panic attack or panic like symptoms. These fears typically involve characteristic situations that include being outside the home alone, being in a crowd or standing in a line, being on a bridge, and traveling in a bus, train, or automobile. The situations are avoided, travel is restricted, or else are endured with marked distress or with anxiety about having a panic attack or panic like symptoms, or require the presence of a companion. The anxiety of phobic avoidance is not better accounted for by another mental disorder. This is not a separate disorder. Patients who meet the criteria for this are diagnosed with either panic disorder and with agoraphobia, or this without history of panic disorder, depending on the presence or absence of panic disorder. When this develops, it usually does so within the first year of recurrent panic attacks. For some individuals, as panic attacks decrease, this decreases. For others, there is no such relationship because people with this avoid situations that are associated with past panic attacks. They do not learn that they can be in such situations without having a panic attack. So, panic attack refers to a specific period of intense dread, fear, or a sense of imminent doom, accompanied by physical symptoms of a pounding heart, then shortness of breath, shakiness, and sweating. During a panic attack, the symptoms generally begin quickly, peak over a few minutes, and disappear within an hour. In some cases, panic attacks are cured. They are associated with a particular object, situations, or sensations. In other cases, panic attacks are uncured. They are spontaneous. They come out of the blue and are not associated with a particular object or situation. Panic attacks can occur at any time, even while sleeping, referred to as nocturnal panic attacks. So, recurrent panic attacks may interfere with daily life, for example, if they occur at a bus or at work, and cause the individual to leave the situation to return home or seek medical help. The symptoms of a panic attack are so unpleasant that people who suffer from this disorder may try to prevent another attack by avoiding environments and activities that increase their heart rates. A typical panic attack involves a discrete period of intense fear or discomfort in which at least four of the following symptoms develop abruptly and reach a peak within 10 minutes: palpitations, pounding heart or accelerated heart rate, sweating, trembling or shaking, sensations of shortness of breath or smothering, then feeling of choking, chest pain or discomfort, nausea or abdominal distress. Abdominal distress might be there. Then feeling dizzy, unsteady, light-headed or faint. Then derealization, feeling of unreality or depersonalization, being detached from oneself, fear of losing control or going crazy, fear of dying, and numbness or tingling sensations like paresthesia, 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 chills or hot flushes. Then tomorrow we are going to learn about panic disorders. So stay tuned for that. Thank you so much for listening this video.